So welcome everyone once again to this second day of our working group meetings. I'm very happy to see again a lot of faces. Yesterday we talked about the activities and the outputs of our action. We explained the different tools that we are able to provide to support you in your work. And today we will give the floor to several of our members, also to demonstrate what we can achieve with this machinery that we have set up. For the people that weren't able to join yesterday, I will give a very brief overview of who we are, what we do, and how we can support you. So we are the European Burden of Disease Network, with an aim to serve as a technical platform to integrate and strengthen capacity in burden of disease assessment across Europe and beyond. Today we have more than 300 members in our country, in our network, mainly individuals affiliated to European countries and institutes, but we also have an international dimension with today over 50 countries being represented. We are structured in 5 working groups, which each have a working group leader and co-leader. We have 3 vertical pillars focused on specific applications of burden of disease, the NCDs, infectious diseases, and risk factors. And we have 2 horizontal pillars focusing on transversal aspects such as the methods and knowledge transfer. In yesterday's meeting, we also discussed a new approach by which we will be able to work in a more specific and more dedicated way. And that's the setup of a number of specific task forces dealing with, for instance, COVID-19 or PFAS or social inequalities or other highly specific topics. I will come back to this later on. But for those of you that didn't attend yesterday's meeting, please follow this link, and maybe someone can also put the link in the chat. This link will guide you or bring you to a Google spreadsheet where you are able to indicate or propose a new task force or put your name to become a member of one of the already proposed task forces. At the end of today's meeting, I will talk more about this and explain a bit more the process for this. But as for now, I just wanted to highlight this possibility. So please have a look at this. Through our cost action, we are able to fund and reimburse a number of activities and tools. And this will help you to build and expose your capacity in burden of disease assessment. So we are able to organize meetings, a variety of meetings going from larger conferences to dedicated working group meetings or task force meetings. We are also able to support dissemination activities, including open access publication fees. And we accommodate a large number of capacity building activities, ranging from training schools where multiple people get together and get trained on specific concepts, and also individual mobility activities where people can go to a conference to present their work, interact with other researchers in a physical, a face-to-face, or a virtual way. If I may summarize all these activities, they are drilled down to this machinery of 3 interlinked activities. So we are able to support networking, to become a network, to be a network, to be able to meet and get to know each other. We are able to support capacity building in training schools and individual capacity building initiatives. And the results of these processes will lead to a number of joint research activities that will, of course, also lead to joint publications. And the idea of today's session is to show you, to put this theory into practice, to show you some of the outputs of this machinery. And as you will see, these outputs range from the pure networking aspects, where people have performed burden of disease assessments independent of the network, but are willing to show and share their experiences and expertise. Some of the activities have benefited from interaction within the network, from capacity building or networking. Activities, calculations that would have been done also without the network, but that benefited quite a lot from the network. And then we have a number of publications or presentations that wouldn't have existed without our network. So presentations that show the results of direct outputs of our activities. So this is what we will see today. First, we will have a number of oral presentations, and afterwards there will be a short session of pitch presentations for a number of posters. We will get started in a moment with the first presentation by Declan Moran on the burden of COVID-19 in the Republic of Ireland. There will be in this session a second presentation on COVID-19 and international projects. Then we will have two presentations related more to non-communicable diseases. We will then stop for a short break and continue this session with two presentations on more methodological aspects related to mortality and causes of death. And we will conclude with two presentations that focus on environmental risk factors. We'll then also have our poster session. We will already start showing the posters during our coffee breaks, but at the end of the meeting, we will ask the presenters to highlight their work in a couple of minutes. We will conclude today's session and the working group meetings by an overview of the possible next steps, also referring back to this idea of task forces. And we also want to have a group photo at the end of our meeting, so please make sure to stay on board until the end of the meeting. So with that, we are slowly getting ready to start our oral presentation session. And as mentioned, the first presentation will be by Declan Moran from the University College Cork in Ireland, who will be presenting initial estimates of DALYs associated with COVID-19 in the Republic of Ireland. And this is an activity that has benefited quite a lot from the COVID-19 task force, which is led by our colleague Sarah Pires. The presentation is pre-recorded, so I will go to the recording. If you wouldn't hear the sound or not well enough, please make some noise. So hopefully it should work well.
There is no sound.
Yeah, or it's very low, I think.
Yeah, very, very low.
Okay, sorry, then let me restart. Thanks for letting me know. I'll try again, so please let me know if you hear the
Public Health in University College Cork.
Okay.
Study was estimating DALYs directly associated with COVID-19 in the Republic of Ireland the first full year. These are my co-authors, Sarah Montero Perez, Grant Wiper, Brett de Vlieshour, Sarah Kusheri, and Zubair Kabir. So, an introduction. There's been a wide international disparity relating to the direct impact on population health relating to COVID-19. Burden of disease frameworks facilitate estimation of disease impact to be translated into a single measure, such as a disability adjusted life year, DALYs achieved this through standardizing the effects of morbidity and mortality as a function of time. The DALY is also one of the most internationally used summary measures of population health, and it is a key metric in the Global Burden of Disease study. DALYs facilitate comparison of diseases against one another, localized regions, or specified demographic groups. So background. The first case of COVID-19 was seen in Ireland in February 29th, 2020. By March 12th, then the Irish government had initiated a limited lockdown, and this was further extended to a full lockdown on the 27th of March that year. Ireland continues to fight the COVID-19 pandemic, although in recent days, much of the restrictions have been lifted. So the parameters of this study was the direct impact of COVID-19 in the Republic of Ireland. And the duration was March 1st, 2020 to February 28, 2021. And this was the first full year of the pandemic. So the methods used in this study were based on the European Burden of Disease Network and the ECDC's Consensus Disease Model. And DALYs were calculated as the sum of years of life lost and the years lived with disability. In this study, we only used publicly available data. The data was sourced from data.gov.ie. This website collates data from several organisations in Ireland. Most notably, in terms of this study, we used data from the Central Statistics Office, the Health Protection Surveillance Centre, Health Service Executive, and the Department of Health. So methods. YLL, or years of life lost, is the product of the number of deaths and the average remaining life expectancy at that time of death. For these inputs, we used incidence data, which was published by the CSO for the events on the CIDR system. And for remaining life expectancy, we used the GBD standard life tables for 2019 for each sex. For YLD then, is the product of the number of incident cases, the average duration until death or recovery, and the disability weight. For the inputs for our YLD, we used data from the data.gov.ie. Duration data was from multiple sources, and disability weights were from the GBD 2019 study for infectious diseases of the lower respiratory tract. Also for YLD, we developed 5 different health states. These were again from the European Burden of Disease Network at the ECDC Consensus Disease Model, and those range from asymptomatic, moderate, severe, critical, and post-acute consequences, which captures long COVID. For data analysis then, results are scaled by a factor of 1 is 365.25. Uncertainty intervals were derived from the input variables, upper and lower confidence intervals. Our main uncertainty was in relation to the transition probability and the duration of health state post-acute consequences. The sensitivity analysis assessed a combination of assumptions to maximize and minimize the post-acute consequences health state. In terms of results then, we found that there was 220,273 confirmed cases of COVID-19. From that, there was 4,500 deaths. Of the total symptomatic cases, 6.5% required hospitalization, and of those hospitalized, just under 11% required treatment in an intensive care unit. And we estimated overall DALYs of just over 51,500. We found that the mortality measure, YLL, contributed 98.7% towards the DALYs. This is consistent with other burden of disease studies that have been done in the EU region. The largest contributing subpopulation were females, 65 to 79. However, the largest DALYs per 100,000 was seen in the male 80 plus population, and that was just under 13,000. We estimate 11.5 DALYs per death. Just a quick graph or two now just to show the findings. So we see that moderate cases were the overwhelming health state. We see that infections were centered around the 25 to 44 age group. However, we see mortality overwhelmingly informed by the 65 plus categories. The results of the sensitivity analysis show a minimum DALY of just over 51,000 and a maximum of just over 59,000. Overall, DALYs were marginally higher in males than females. The DALY contribution significantly increased in populations over 65. This biological inequality suggests that the higher age groups of both male and female were at a higher risk, particularly of mortality from COVID-19. To put this into an Irish context, we measured our findings against GBD data from 2019, and we estimate that COVID-19 is likely the second highest cause of death in the Republic of Ireland over our study's duration. COVID-19, because of the mortality, is also likely to have the second highest YLL. DALYs are comparable to estimates relating to unintentional injuries. However, YLDs are comparable to non-Hodgkin lymphoma or idiopathic developmental intellectual disability. In terms of limitations, privacy restrictions meant that mortality data for population counts of less than 5 weren't publicly available. So we estimated a resulting max underestimation of the DALYs of just over 1,100. Due to the recency of the COVID-19 pandemic, no attempt was made to account for multimorbidity. Comparison of COVID-19 cases with the GBD study for 2019 was for contextualization only. And given the age profile of deaths relating to COVID-19, it's implausible that all those deaths are additional. In terms of policy and research implications, older adults bore an unequal health burden, which ultimately results in greater DALYs for this population, and those DALYs were overwhelmingly informed by mortality. So an obvious strategy for DALY reduction would be to focus on mortality reduction, with particular focus on high-risk groups. We would recommend areas for future research include examining the impact of the vaccination rollout, the formulation of COVID-19 specific disability weights, and an extensive burden of disease study relating to the indirect results of the pandemic. I would like to acknowledge my co-authors for their support and input, the COVID-19 Burden EU Task Force, and University College Cork. This study is currently undergoing peer review with the International Journal of Public Health and is available at the below link on the MedRx server. Thank you very much.
Yes, perfect. Thanks a lot, Declan, for virtually presenting your work, but you're also here with us in a live and non-hologram version. Yes, indeed. We have quite some time for questions. If you would have a question for Declan, feel free to either type it in the chat or you can also raise your hand to ask to take the floor and then unmute yourself and directly ask the question to Declan. And I see that Grant also put the link to the preprint paper that Declan mentioned in the chat. Thanks a lot for that. Maybe a question to get the discussion going. Is there already information in Ireland today about how causes of death were different in the pandemic years? Because you mentioned that you could compare with previous GBD estimates, and then ischemic heart disease would be still number one, followed by COVID. Do you have any current or recent insights in the actual causes of death and how they ranked and compared?
No, I don't have in the actual causes. No, not at this moment.
Yeah, so there's some delay in obtaining and compiling those data.
Yeah.
Yeah. Okay.
Hi, Declan. Thanks for the talk.
Thanks, God.
I just had a question about one of your future directions. What exactly did you want to do with multimorbidity data?
Yeah, well, I suppose it's interesting to go back over all the data for that time and how much can we actually attribute to COVID-19 in terms of the impact then as well of multimorbidity. Who was at a higher risk? You know, what morbidity was increasing risk for people?
So there have been quite a few studies already looking at general risk factors for mortality or for hospital admission that look at the relative risks associated with different comorbid conditions. I'm just wondering how this would contribute to the burden estimates. Do you mean you would like to stratify the burden by, for example, people with underlying pulmonary disease or underlying heart conditions versus everyone else?
Yeah, I mean, yeah, we could stratify the burden like that. Yeah, absolutely.
I see a question in the chat from Seval asking if you have performed risk factor analysis. Maybe this is a bit linked to the question of Scott, because you could also see this comorbidities as risk factors and calculate the contribution of the risk factors in a comparative risk analysis framework. And I saw a paper a couple of days or weeks ago from an American study where they did this. I can put the link in the chat if I would find it, but I think this would be a very valuable avenue for further research. So definitely something that you and we all could consider when talking about COVID tallies. Maybe Grant, you have some extra thoughts on that?
So yeah, I think the thoughts that were coming to mind were that paper that you were chatting about. I think maybe in kind of the case of Declan's just taking the results at kind of face value, I interpreted that as you hadn't adjusted the disability weights for comorbidity rather than looking to adjust the YLL of some sorts, because that would mean that you could not compare like for like with the other health outcomes. Thanks for that, Greg.
Yeah, thanks. And I put the link in the chat so that everyone can have a look. Okay. And I see that Subair also added that in Ireland, you are indeed intending to explore individual level data, so to go a bit deeper into these estimates. Okay. We have time for maybe one final quick question for Declan. Going once, twice. No. So if no further questions, and again, don't hesitate to contact Declan directly or have a look at the preprint. So yeah, Declan, thanks once again for your contribution and for the nice piece of work that you and Subair and the colleagues have done. Thanks a lot.
Thank you, Greg. Thank you.
Yes. Great. I suggest we can then move on to our next speaker, which is Kiefer Cowley from the Robert Koch Institute in Germany. And she will be presenting us the BOCO-19 project. She will, of course, tell you all the details. It's a very intriguing and interesting project where international collaboration is at the heart. So I'm very excited to learn more about this project. So please feel free to take the floor. Thank you.
Thanks, Brecht. Thanks a lot. I think you can see my presentation now.
Yeah, all is perfect. Thank you.
Okay, great. Yeah, so sorry, I just have to move a window here. Yes, my presentation is also about burden of disease due to COVID. For our project, we're actually using the short name BOCO-19. You can see our project logo up on the top left of this slide. The project has multiple partners, and we're focusing on harmonization of population health metrics for the surveillance of dynamic outbreaks. And in the author list here, you can see members of our steering committee for the project. I'm trying to go down. The project, as I mentioned, contains multiple different partners, 14 partners from different countries in Southeast Europe, the Caucasus and Central Asia. I'll talk more about that in a moment. Our overall aim is to harmonize BOD methodology for pandemic monitoring and their surveillance of dynamic outbreaks using COVID-19 as an example. Our specific objectives are, of course, to develop this harmonized methodology, to implement or calculate the BOD indicators, YLL, YLD, and DALYs, and of course, we would like to disseminate our methods and results from the project. The project is essentially, or largely, a scientific networking and platform project, which allows for methodological learnings and exchange. It's funded by the German Ministry of Health under the Global Health Protection Programme, and I've included some links here to the Global Health Protection Programme webpage, the general one, as well as a specific page about our project, BOCO19. We at the Robert Koch Institute here in Berlin are responsible for the project coordination, but we are also receiving coordination support from our partners in Serbia and in Kazakhstan. The project has also received some support primarily thus far in terms of capacity building and training from members of this network, for which we're very grateful. And we are also receiving some support from WHO regional and country offices, so far largely with regard to supporting data access requests by our partners. On this slide, you can see our different partners. In Southeast Europe, we have 7 partners in 6 different countries. In the Southern Caucasus and Central Asia, we have 7 partners in 7 countries, so 14 partners in total. The project is running for 2 years. It started in May of last year and will run until April 2023. On this slide, you can see a timeline of our activities. At kickoff in May, June last year, we had a number of introductory meetings, and some of my colleagues conducted individual country interviews with each of our partners to understand data access and availability in their country with regard to COVID-19 data and the data that we'll need for our project and calculations. In November last year, we managed to do an in-person workshop in Belgrade in Serbia. It was very nice to have the chance to do that just before Omicron took off and made travel difficult again, but we had an opportunity to meet then, and we do hope to be able to do 2 further in-person meetings this year, probably here in Germany. These we are naming data labs. We want to focus on calculation of YLLs and YLDs with our partners at these meetings. And then towards the end of the project next year, we'll have a wrap-up workshop. And of course, between all of these events, there's various pieces of work going on. The work of the project is divided into 4 work packages, and I'll briefly talk about the first 2 work packages now, which we've mainly worked on so far. So work package 1 has really been project kickoff and preparation, discussing our project aims and goals, and providing an introduction to BOD concepts. As I mentioned, we also conducted the individual country interviews, and I'll show you some results from those in just a moment. And we were also busy making preparations for our baseline workshop, which I'll also talk about shortly. Yeah, we thought we would show you some results from the data availability interviews. You can see here on the simple chart on the left that gladly 12 of our 14 partners said to us that COVID-19 data was at least partially available to them in their country. But here on the right, you can see some of the reasons which were given with regard to perhaps issues or difficulties getting access to the data, or hurdles which would have to be overcome. 5 project partners mentioned there were authority or access right restrictions in some countries. Some partners mentioned that the data themselves were limited, perhaps incomplete or not available in the desired level of detail. And other concerns raised were security concerns, or that another project owned the data. We also asked our partners what kind of support might be helpful to allow them to get access to data. 6 partners mentioned, we can see here on the left, mentioned that high-level authority support would be helpful, which is one thing that the WHO country and regional offices have been aiming to help us with by providing letters of support for our project and for data access. And other things mentioned were technical assistance and financial support, but some partners mentioned that support wasn't actually needed. That was mentioned by 3 partners. And then we also asked how long it might take to get access to data, and many partners, 10 out of 14, said that they could probably get access to data within 2 or 3 weeks, which was very encouraging. 4 partners said it might take longer than that, up to 1 to 3 months. I mentioned we were able to conduct our baseline workshop in Belgrade in November. During this, we had lectures and practical exercises which covered general concepts of burden of disease, but also specific sessions on the burden of COVID-19. And arising out of this meeting, we created 3 working groups for our project, a data working group, a methods working group, and a writing group. The data working group is busy with the finalization of a data collection template, which we're preparing, and all partners will need to fill out with the data that we need for our calculations. The methods working group is taking forward topics which we already started to discuss in the baseline workshop, but for which we didn't have time to discuss fully and reach solutions for all. And I'll talk again about the methods working group in a moment. And the writing group is responsible for thinking about publications and which publications might arise out of our project, and for communication and dissemination. I've just listed here a few headline bullet points of topics which the methods working group are working on. Some issues which we've already managed to reach agreement or consensus on, and some more complex topics we haven't fully discussed through yet. But the first 2 bullet points are things we have agreed on. So with regard to life expectancy tables, we plan to use the GBD 2019 life expectancy tables, but we did also discuss the possibility of creating a regional aspirational life expectancy table for the countries contained in our project. Obviously, we want to use GBD for reasons of comparability between, not only between countries in our project, but also other countries who have published data on the burden of COVID. Again, for comparability reasons, for a standard population, we decided we would use the GBD World Standard Population for comparability inside and outside of our project. And then the last 2 points we are still sort of very much working on. We have a subgroup which is concerned with tackling underestimation of COVID deaths in our partner countries and how we need to approach this and the issue of excess mortality. And we have not finalized or actually managed to discuss in detail yet which disease model and exact input parameters we might use. Yeah, so I will just sum up now with some key messages. I think we're all aware by this point that timely information on the impact of COVID is needed, and that international comparability is important, and certainly important for our project. And our project has established a nice network of partners and also provides support and capacity building for the calculation of the burden of COVID-19. And that brings me to the end. I'm afraid I omitted an acknowledgement slide, which is certainly something of an admission, but I would acknowledge all of our partners for their efforts and input into the project, for which they don't receive specific support outside of capacity building and training, and also members of this network and all our coordination support partners. Thank you.
Yeah, perfect. Thanks a lot, Kiefer. And also want to thank you from our point of view, because this is a very excellent project that can lead to a lot of win-wins where we can work together and help and support each other. Also thanks to everyone involved in this project and that is attending this meeting. I know there's several colleagues from the involved countries also part of our network and joining this meeting. So thank you all, and very much looking forward to the next steps and outputs of this project. We again have some time for questions. So if you have a question, feel free to ask them directly or put them in the chat, whatever you feel most comfortable with.
Hello, it's Peter, if I may.
Sure, sure.
Yes, thank you. Both these presentations are, of course, very timely and most interesting. I mean, there are some issues that I feel will take more time to evaluate. For example, the issue of deferred care. People have not come to cancer screening, for example. Also, the excess deaths is difficult because you have some causes of death that perhaps been reduced, traffic accidents, for example. So I would feel that there are some issues regarding the long-term effect of COVID that still are difficult to evaluate. Have you thought about these other more long-term aspects?
So I think probably within our project, the answer to that specific question is probably no. I think we're going to focus on the direct impacts of COVID, but I certainly agree with you that, I mean, I have to say that burden of disease is actually a new topic for me in the last month, so I'm learning alongside many of our project partners here, and so on the technicalities of it and the calculations, it's yeah, a new topic for me. But yeah, I personally think that the issues you've mentioned are very interesting with regard to COVID. I'm sure there's others here at the meeting who can provide more thoughts or expertise.
Yeah, definitely a very relevant question. Maybe if I may ask Grant and then perhaps Sarah to add some additional thoughts to that. Grant?
Okay. Sorry, could you take me next? My laptop's about to run out.
Okay, no problem. Yeah, Sarah, I don't know if you had any thoughts on this.
No, not specifically. I think these are relevant points for all of us doing burden of COVID studies at this stage. And it's something that we've discussed also in the task force and how we should address. So we're working towards more harmonized methods to do it. Brent, you're back.
Yes, I'm back. So yeah, probably we could speak a bit about that from our experiences from the Scottish study. Kind of some of the stuff that Peter's mentioned about possibly road traffic accidents, things like that decreasing. Obviously, things are indicators are showing that they're increasing. Mental health, cancer could increase through delayed care, etc. So for us, it's a bit difficult because obviously we tend to use these kind of DALIs as kind of long-term priorities, and it's quite difficult to know how these are going to, in a kind of DALI framework, how we can start applying, say, the lags from the cancer, people not being screened, and how they translate into deaths. Will that result in an increase in more ill-defined deaths because the diagnosis hasn't been made? So I guess we're, from a kind of burden of disease perspective, we could be a bit kind of delayed until we start seeing these things playing out to a trend, especially as kind of different countries have been hit with different waves of COVID. So I think kind of looking at running a comprehensive burden of disease study is going to be really difficult over the next, not just for the independent studies, but for the GBD, because obviously people have been maybe getting remote consultations rather than face-to-face. So there's lots of kind of coding issues to unpick there as well. So I know that's a bit of a holding kind of response, but it's very difficult to kind of start weighing these out because there's lots of uncertainties within both.
Yeah, indeed, but definitely a very important topic. So I would greatly encourage you and Sarah to take this further within the COVID task force, because now we've only focused on the direct impact, but the crisis, of course, had and still has a health impact that is much wider than just these cases, hospitalizations, and that. So definitely of interest to also, look into that. So thanks a lot, Peter. Great. With that, we can move on with our next presentation.
Right. I had one more question actually.
Sure.
It was a methods question. It was regarding the use of the world standard population. So we know that we've obviously done some comparisons there, and it can kind of yield differences in how things are ranked. Can understand why you would maybe use the world standard, because most of the outputs are in that format when we're talking about kind of DALIs or GBD metrics. GBD have mentioned that they would think about incorporating some of these different standard populations, and presumably by that it might not be the Eurostat one, it might be one that's based upon their population estimates. But I think in terms of how that might impact your findings when we're expecting the COVID burden to mostly be in the elderly, and we're using a standard population that is focused on the kind of younger ages, then it's just maybe that's something that's been talked through. But I thought that it was just worth highlighting.
Maybe I can add something to this. We have discussed very many different options, and our decision is still not final. But we have in our project countries from Central Asia, where the population is has a totally other structure and is more nearer to the world standard population of the GBD. So it will not affect really all of the countries with assigning the wrong age structure of the population. And we are thinking also of dividing eventually the countries in two different groups and using the age standardization so that they can compare in between themselves when they have a similar age structure. So it is not really discussed till the end. And the other point is, of course, we are learning a lot from your experience. We don't have here any ranking of the diseases, so we are not facing this problem that suddenly the neonatal diseases will be more heavily weighted in a total burden of disease study. Yes, so but we have discussed a lot this issue, so we are aware of this kind of methodological problems.
Okay, great, thanks. And maybe Grant, in the meantime, you can put the link to your paper on the comparison of world and other standard populations in the chat. So then I suggest we move on with the program, and then our third speaker of the day is Vanessa Corazzo. She's one of my PhD students, and I see that she is in office, so very good. And she will be presenting initial work of our Belgian National Burden of Disease Study, a first component focusing on the non-fatal burden of cancer. And this work also benefited from collaboration within the network, so we managed to get inputs and feedback from our Scottish colleagues who have also gone through the same process. So Vanessa, please feel free to go ahead. Thank you.
Thank you. Can you hear me well and see my screen?
Oh, no, you sound very metallic, not Italian, but metallic, sorry.
Also Italian.
Yeah.
Wait, I will try with the...
Yeah. And please keep it close to your mouth, then it will give the best quality.
Can you hear me better now?
Yeah, and please keep it close to your mouth and
Okay, yes.
Okay, perfect. Thank you.
Okay, hello everybody. So I'm Vanessa Grasso and I'm a PhD student at Cienzano and the University of Ghent in Belgium. So I've been collaborating with the cost action since the beginning, since I'm going to estimate the burden with DALIs of different non-communicable diseases. And also I'm going to assess the burden attributable to overweight and obesity. So the work I'm going to present today is part of my PhD, but is also part of a bigger project called the Belgian Burden of Disease Study, in where we aim to assess the health status of the Belgian population using national available data. And we want to summarize this burden both in terms of mortality and morbidity. And what better than use the disability adjusted life years for this? So today I'm going to present, I'm going to focus on cancer, since we all know that is a major contributor to the overall burden of disease. And also because until now, local estimates were lacking for this disease. More specifically, I'm going to focus on the non-fatal burden of cancer. We computed incidence and prevalence-based years of life lived with disability for all cancer types. And well, in addition, there is also going to be a work on fatal burden of cancer where we computed years of life lost. But this is a work in progress. So we had a look at data from 2004 to 2019. That was the latest year available. And we used a combination of different data sources that represented the best available options in Belgium. So we used data from the Belgian Cancer Registry Foundation. That is an institution in Belgium that collects all the cancer diagnosis in the Belgian territory and is known for a good quality of the data and completeness. So we received incidence and survival estimates by cancer type, age, gender, and region. Then we also used data from the Global Burden of Disease Study, where we took the disease models they used for cancer patients and also the disability weights. We also used the population data from StatBel, that is the National Statistical Bureau. And we also conducted a small expert elicitation to obtain the proportion of oncological patients that have a complication in the course of their disease. And this was done for some types of cancer. So for example, for breast cancer patient, we were asking to oncologists which proportion of this patient usually has a mastectomy, or for colorectal cancer patients, how many of these have colostomy? So as I was saying in the beginning, we computed two measures, incidence and prevalence. And out of these estimates, we also compute two types of YLDs, so incidence-based and prevalence-based YLDs. For the incidence estimates, the work was pretty easy. So we received the estimates from the Belgian Cancer Registry, and then we adopted the GBD disease model for the cancer types. For the prevalence estimates, we wanted to pass from incidence to prevalence, and we used a microsimulation model. So we projected the time spent in different health states for each incident cohort. And in here, you can see a small representation of the disease models. So you can see there are two models, one for the people that died within 10 years from diagnosis, and the people that survived after 10 years of diagnosis. And this distinction was done looking at the survival probabilities that we also received from the Belgian Cancer Registry. And at this point, we were able to simulate future health states for each year, each age, sex, region, and cancer type. Our prevalence was defined as a 10-year prevalence. So from 2013 onwards, we were able to define prevalence as the sum of person months spent in every different health states. So some results. So these are incidence-based rates. You can see in the graphs here, the top 5 cancer diagnosed in men from 2004 to 2019. And you can see plotted both the age standardized incidence rate and the age standardized YLDs rate. And we can see, for example, that for men, prostate cancer has been the cancer type with the highest age standardized incidence rate and YLD rate. And then if we look at the trends of the top 5 cancers, we see that from 2004 to 2019, there has been a decrease in almost all top cancer types with different proportions, of course. But we can also see that non-melanoma skin cancer shows an increase in this time span. For women, the situation is quite different. So here you see plotted the top 5 cancers diagnosed in women from 2004 to 2019. And for example, breast cancer has the highest age standardized incidence rate and YLD rate. And here the trends are different because almost all top 5 cancer types have an increase. The only one that decreased during time is colorectal cancer, so the orange line. And we can observe that, for example, malignant melanoma and non-melanoma skin cancer more than doubled since 2004. So here, just for information, you see the prevalence-based results that they confirm the results and the trends from the incidence-based rates. So I'm not going to go too much in detail here. So the messages I want to leave you today is that from 2004 to 2019, sorry, Belgium experienced an increase in cancer age standardized incidence rates and also prevalence rates. In 2019, there were more than 80,000 new cancer diagnosed. and more than 430,000 people were living with cancer. And this corresponded to around 50,000 YLDs each year. But also an important message is that most of the increase we see in the age standardized rate is attributed to the increase of non-melanoma skin cancer cases. And I think this is an important message for future public health actions. Also, these are two snapshots of the outcomes that came out from the project. So the first one is a Shiny app that we developed with my colleagues in Cienzano, and it includes all the outcomes that you saw today, but also for all cancer types. And then you can also see our brand new publication with the same outcomes. Also, I think it's interesting for you to know the future perspectives of this study. So as I was saying in the beginning, we also aim to have a publication or to have results on the fatal burden of cancer. And we plan to also analyze the cost attributable to cancer in Belgium. I would like to thank you very much for the attention. And if you have any questions, you can ask me here or contact me to my email. Thank you very much.
Yeah, thanks a lot, Vanessa, for the excellent presentation. I see that we already have two questions in the chat that we can take before moving on with the next speaker. So first, Ricardo was asking whether you could comment on the fact that breast cancer, for instance, was most prevalent, but not per se contributing the most YLD?
So yeah, the breast cancer has become like a big has a big impact in almost all countries in Europe, I would say. But yeah, due to the advances in how do you say in yes, living with the cancer and like also the early stage diagnosis, we're able to reduce the burden due to disability. So yeah, we diagnose more and more in cancers because we also are able to diagnose them at an early stage. This disability is lower than the actual number of cases.
Okay, and then second question from Romana, asking about the increase in melanoma cancer, especially among female, and if there would be any potential explanation or reason for this increase. Thank you.
Well, the increase in skin cancer, I think it's a common trend in the past years, probably not only in Belgium. And yeah, it's very alarming because it's speeding up at constant and increasing speed. Well, but the reason of this increase is probably due to different risk factors that we are exposed to today. Not sure if this is different for female or male, but yeah, of course, gender might play a role. Maybe we'll find out that female are more exposed to some risk factors than others. But yeah, at the moment, we just know there is an alarming trend in the overall population.
Okay, thanks. Then I see some more questions. Maybe Vanessa, you can take them if more come in the chat, but one final one that you can take now. Zubair is asking about the future cost study, and he's wondering if you could already share some thoughts on the type of study that will be used.
Yes, so I hope that we will be able to start working on the cost very soon. We're still waiting on the data, but what we aim to do is to try to estimate a general cost of the disease. So we will probably be able to differentiate between hospitalization costs, medication costs, and ambulatory costs. And we want to do this for each cancer type separately. Yeah, so this is the general aim, to have an idea of how much, for example, on average, a breast cancer patient costs the Belgian society. But hopefully there is going to be some outcome very soon.
Yes, indeed. Thanks a lot. Thanks. There's a final question from Carl, but maybe you can answer that by chat so that we can continue with the program. But thanks a lot.
Thank you.
Thanks also for everyone with your questions. The fourth and final speaker of this first slot of presentations will be Pericles Charalampous, working at the Erasmus Medical Center in the Netherlands. He's one of the driving forces behind the systematic literature reviews that we are conducting within our action, and he will be presenting the results and experience of one of the first of these reviews, focusing on non-communicable diseases and injuries. So Pericles, thanks a lot, and feel free to take the floor and start your presentation. Thank you.
Yes, thank you, Brecht. Can you see my screen?
Yes, but not yet the full screen. So if you click on the icon or, yeah, perfect.
Yep,
Thank you.
nice. Thank you very much. So I'm Pericles. I'm a junior researcher at the Department of Public Health in the Erasmus Medical Center University. And today I will give you an overview about the data input sources that have been used to assess the burden of non-communicable diseases and injuries. The methods and results presented here came from the series of systematic literature reviews that we set within the Burden EU Cost Action Network. So, as you may know, an earlier systematic review showed that many independent burden of disease studies have been conducted across Europe, and there is not yet available a mapping exercise on the data input sources that have been used to assess the burden of non-communicable diseases and injuries. The assessment of the burden of non-communicable diseases and injuries requires high-quality data. So within the systematic literature reviews, we aimed to map how many burden of disease assessments have been performed across Europe and in which European countries, and then to map the data input sources that have been used to assess both elements, mortality and morbidity. So we screened several international databases, platforms, and search engines, gray literature also from multiple sources and websites, and we also looked the websites of public health agencies across European countries, and we also contact the Burden EU collaborators or members, and we also perform hand searching of the included burden of disease studies. In this slide, you can see the specific elements that we extracted from each burden of disease studies. For this presentation, I will focus on the mortality and morbidity data input sources. Yes, so for the first systematic review focusing on the non-communicable diseases, 163 studies were included. 89 studies out of 163 studies perform an NCD-specific burden of disease assessment. And for the second systematic review focusing on the injury burden of disease studies, 125 studies were included. 48 out of these studies performed an injury-specific burden of disease assessments. So in this figure, you can see a map of the data sources that were used to assess morbidity and mortality for non-communicable diseases. In this figure, the size and the color of each circle corresponds to the amount of burden of disease studies for each European country, and the data source of morbidity on the left side and mortality on the right side. So the bigger and the lighter the circle, the higher amount of burden of disease studies estimating the burden of non-communicable diseases. As you can clearly see, over half of the independent burden of disease studies measuring the burden of non-communicable diseases derived morbidity data from routine administrative and survey databases, including hospital discharges, and mortality data from causes of death registration system. The same figure applies for the second systematic literature review focusing on the injury burden of disease studies. And you can see that 60% of the independent injury burden of disease studies derived morbidity data from injury surveillance systems, national injury surveillance system, and 1 to 3 independent injury burden of disease studies derived mortality data from cause of death registration system and or vital registration systems. The results from both systematic literature reviews showed that very few burden of disease studies reported on the data quality. We believe that the reporting of the quality of epidemiological data input sources can be improved by the development of guidelines, of checklists for evaluating both the mortality and morbidity data in future burden of disease studies by reporting, for example, the level of completeness or coverage or the accuracy of vital registration system, national registration system. I think that was it. Yes, and I would like to thank, of course, the core group of the Burden EU network, the Cost Action CA 18218, and of course all the members of this Cost Action DAO for their contribution and the valuable input. Thank you very much for your attention.
Yes, excellent. Thanks a lot, Pericles. And indeed, good to stress that this is really a collaborative effort. So we have done our best to reach out to our network and seek support and contributions from everyone. And this indeed led to a long list of co-authors. So I'm very proud and grateful for this collaborative effort. So thanks a lot for leading this.
Thank you very much.
I see a question in the chat.
Yes, of course.
Despite presenting similar percentages, the studies that reported data of mortality and morbidity were not the same studies. Is that a correct assumption?
Okay, despite percentage. Yes, I would say yes.
So it's more a coincidence than that.
Yes.
Yeah. Okay, that's
Thanks for the question, Ricardo. Yes.
Yeah, indeed. Okay. And then at the end, you mentioned the idea for promoting checklists for data quality. Do you actually know if there are gold standard checklists for evaluating quality of data inputs? So if someone would come to you and hear this and they would then ask, okay, can you suggest me a checklist that I could use in this respect?
Yes, thank you for the question. I'm not aware for any checklist, to be honest.
Yeah, I'm asking the question because I'm also not very familiar with such checklists for very generic studies or indicators or parameters. So most checklists that I know of refer to very specific studies. But for generic epidemiological data inputs, I wouldn't know what to use.
True.
More generic checklist. For example, I came across a checklist that checks the quality of a systematic literature review. So whether you performed double extraction data and screening of the papers. So I think that something like this, without like a specific assumptions on, for example, as we have for the clinical trials, where there are questions that are very specific to this type of study. Yes, could be something more general. Questions that check the quality of the reporting, for example, as we wanted to do for the DALIs.
Yeah. Okay. Thanks. Would there be any further questions for Pericles? And in any case, this is just one of a series of outputs and reviews. I don't know if you or Juanita could give a quick summary of the status of the other reviews and what we can expect in the coming weeks and months.
Sorry, could you repeat if that was a question for me?
Yeah, so for you or for Juanita, if you could give a quick summary of where we are with the other systematic reviews.
Of course, yeah, sorry.
Thank you.
We have submitted the systematic literature review focusing on the injury burden of disease studies and is currently under review. And I'm currently working on the third systematic review on infectious burden of disease studies, and we finalize the data extraction form. And then I believe all the Burden EU collaborators will receive the opportunity to again provide feedback to our systematic review. And the systematic review on non-communicable diseases is accepted for publication, so will be available very soon because it's currently in press, in preparation. Yes, and I think the systematic review on risk factors is also currently in progress.
Okay, excellent. So very happy to see and hear about this progress. So congratulations once again to everyone involved.
Thank you.
So thanks a lot. And we've now come at the moment where we can take a short break to stretch our legs, get a coffee or go to the toilet, etc. While we have this break, which will last until 2:25 Central European Time, I will show the poster presentations so that you can see them passing by on your screen. But we will then continue with our program of oral presentations in 8 minutes or so. So thanks for now, and see you all again soon.
Excuse me, just a short check. Does my microphone work?
Yeah, Matthias, perfect. Thank you.
Thank you.
Oh, Guido, I hope you were able to stretch your legs during this short break. We're happy to continue with our program now, and next in line will be the next speaker, sorry. So next in line will be two presentations on methodological aspects related to mortality and causes of death from our colleagues in Serbia. And first we will have Alexander Stevanovic from the University of Belgrade, who will talk about differences between registered and expected mortality in Serbia in the year 2020. So Alexander, feel free to share your presentation. Yeah, thanks a lot, and take the floor. Thank you.
Thank you so much, Brecht. Can you see the presentation?
Yeah, we can see and hear you perfectly. Thank you.
Okay, great. Well, okay, great. So, dear colleagues, greetings from Belgrade. It is really a pleasure to be here among you and present the results of our research. You can see it here, differences between the registered and expected mortality in Serbia in 2020. My name is Alexander Stevanovic and I come from the Institute of Social Medicine, University of Belgrade. So, first of all, just to thank my dear colleagues from the Institute of Social Medicine, also School of Public Health and City Institute of Public Health, Statistical Office of Republic of Serbia, and dear Professor Milena Šantrić-Milićević, my mentor. I'm sorry, can you? Okay, I will give you some background and context for this research and results. So the pandemic of COVID-19 started very early in March in Serbia in 2020, and a formation of a COVID-19 crisis team followed. It was created to follow and evaluate epidemiological situation and recommend various social measures in order to mitigate the epidemic. So this pandemic also presented itself as an opportunity to invest in our public healthcare system through infrastructure, through workforce, through buying the new equipment such as ventilators, protective equipment and such, but also to conduct a mass vaccination campaign. We started vaccinating first with Chinese vaccines, Sinopharm, and then all the others followed. I just want to state out that Serbian law recognizes Institute of Public Health as a central institution for health surveillance and data collection. So that institute publishes daily reports on the epidemiological situation in our country. And the other law recognizes the Statistical Office of the Republic of Serbia as the main producer and disseminator of data, the main data holder, including vital statistics. So what was the most important for us? It publishes monthly reports on the number of live births and deaths, as well as many other demographic reports. So we also introduced to our healthcare system very early when the WHO introduced the new ICD codes for coronavirus infection. So you know these two codes, first one when the virus is identified, and the second one where there is a clinical suspicion to the virus. And here you can see, I took a screenshot, I think 3 days ago when I made this presentation. This is from the official government of Serbia website, where we follow the number of confirmed cases and also a total number of deaths since the beginning of the pandemic. You can see that number is above 13,000 at this moment. And you can see also the number of hospitalized patients, patients on ventilators, etc. So, but what is even more interesting is this number of live births and deaths in the last 20 years. So first, you can see, unfortunately, the population of Serbia is shrinking. If we could see the number, mid-year population in 2000 and then just last year. And here you can see the total number of deaths with a minimum and a maximum in 2001 and 2005. But it's very obvious that the number of deaths in 2020, so the year when the pandemic started, is 10,000 deaths above the maximum number registered in the last 20 years. So this was very interesting for us in terms of excess mortality and this difference between what was expected and what was registered. So we got deeper into that. I would just say that just yesterday, this is so very fresh results from the Statistical Office. In their preliminary report, they counted 135,000 deaths, almost 136,000 deaths, which, as you can see on this graph, by far exceeds all mortality rates in the last 20 years. So we can summarize on this slide that the average number of annual deaths in the period of 15 years before the pandemic is around 102,000. And you see the reported number of deaths in 2020 was 116,000, and the expected preliminary number of deaths in last year was 135,000 deaths. But what we also know is that the total confirmed number of COVID-19 cases, according to the government website, is around 13,000. So there is an obvious question: what is the underlying cause of death for 34,000 people? So the surplus we are seeing in 2020 and 2021. We used for this research mortality data from the Statistical Office, and we calculated, actually we got to the expected number of deaths in 2020 as a linear trend for a 5-year period from 2015 to 2019. So this was before the pandemic. And then we compared to what actually happened, the registered number of deaths for the same year. Also, we observed absolute and relative changes in contribution of different causes of death to the all-cause mortality based on the difference between registers and expected number of deaths. So I will show you now what we observed. You see this 5-year period before the pandemic from 2015 to 2019, and then you see the expected, so the linear trend from the 2020, but also what was registered, and you see this big difference between what was expected and what was actually registered. And I think this is even more interesting when you disaggregate this data by different ICD groups. In 2020, you see some really interesting differences. So obviously, what was expected and reported in terms of COVID, we didn't expect any deaths from coronaviruses, but what we reported was 10,356 deaths related to COVID-19. But for example, and we also spoke before in other presentations about injuries, for example, here we have actually a decrease in number of injuries. So you see the reported and expected, which could be maybe due to a lockdown, which was also introduced in Serbia, and different social measures to mitigate the pandemic. Some other ICD groups also decreased, for example, gastrointestinal diseases, or you see here very interesting neoplasms and tumors or cancer, maybe due to underreporting or these patients dying, but there is also a decrease in absolute number of these patients. But among the 22 different ICD disease groups, in 14 groups we saw an increase. And this you can see in the group of other signs and symptoms, which could be due to miscoding, garbage codes, etc., but also to respiratory diseases, and in circulatory diseases, we see actually an increase in the number of reported cases. So here I try to visualize using a very known technique, the relative contribution to all-cause mortality. So this is what was expected in 2020. But of course, as Serbia is a developed country, you can see that NCDs are the leading causes of death: circulatory diseases, stroke, neoplasms, different types of cancers. But what actually happened, you can see on the next slide, is that we got this new cause of death. So the COVID-19 became third leading cause of death in Serbia in 2020, and it's very clear when you put it like this visually. Okay. So what about this surplus of debt? We are not yet talking about the excess mortality. So about this surplus of debt in 2020, what are the main contributors? So we definitely should list COVID-19 with these 10,356 cases in 2020, but also we shouldn't neglect the increase in the absolute number of cases with circulatory diseases and respiratory diseases. I'm very sorry for using these very similar colors. I can actually see it now that maybe it's not very obvious, but I will change these graphs for you to better see that. But these are maybe the three. Also, we can see an increase in other disease groups here. But what is interesting also, some of the surplus of debt is maybe due to a decrease in some other disease groups. So first of all, we see here a decrease in the absolute number of neoplasms or tumors and cancers, but also a decrease in the number of injuries and a decrease actually in gastrointestinal diseases. So these are the main three. What can be concluded then and maybe said as a result of all these results? So the impact of COVID-19 pandemic on the mortality structure is definitely significant. COVID-19 became the third leading cause of death in Serbia. And the difference between what we registered and what we expected definitely surpasses the total number of COVID-19 deaths. So we have to see and research more what actually happened. The difference between what was registered and what was expected was the largest in the disease group of the circulatory and respiratory system. But nevertheless, what is interesting, relative contribution. So relative contribution in percentage of the leading causes of death, the NCDs in Serbia, decreased. Further research, of course, is required to calculate the excess mortality and to explain this surplus in number of deaths. And as I said before, and some of my colleagues mentioned, these possible explanations could include underreporting of COVID-19 cases, miscoding of COVID-19 deaths, complication and sequels such as long COVID, and what is very important, I think, decrease in access to essential health services. We already stated delayed access to care and unmet health needs. So thank you.
Yes, thank you, Alexander. Very important and interesting presentation, and it complements very well the discussions and presentations that we've had just before the break. So thanks a lot for sharing these results with us. I see a question in the chat from Ricardo. He's asking if these results could show that in addition to the direct mortality due to COVID, there is also an effect of the indirect consequences of COVID and the COVID crisis beyond the direct consequences of COVID as a disease.
Thank you, Ricardo. Yes, this is a very interesting topic, which we now have time to research and to think about now that I would say the situation is a little calmer. So definitely we have the direct losses due to COVID. But as you can see now, even with all the underreporting and the miscoding, the difference between what was expected and what was reported is too large to explain it only by direct COVID-19 deaths. So surely we'd have to somehow join this data of excess mortality, but also the data on unmet healthcare needs and also other sociodemographic data to explain, to at least try to explain what actually happened.
Yeah, indeed. And I think, for instance, this difference in circulatory diseases might refer to patients with a stroke or heart attack that didn't get the sufficient or the necessary treatment in time.
Thank you.
Yeah, but Dietrich is asking if this higher number of circulatory diseases could also be linked to undetected COVID. So yeah, the main question here will be how do we disentangle the root causes and to what extent could COVID have played a role even if we didn't detect it?
So this data came from vital statistics where we can only see one code, the main cause of death. We don't have data on morbidity. Of course, we know that COVID, one of the complications of coronavirus infection could be circulatory in terms of thrombosis, embolism, etc. But what we also know is that some circulatory disease patients couldn't get fast access to, for example, treatments such as thrombolysis and coronography, etc. So this is what will be challenging to see what is the root cause, because we for now only have the data on the main cause of death, and we are trying to collect also the data on morbidity, incidence, and prevalence. So we'll see, hopefully, the answer to that question also.
Okay, great. I think this is something that many countries will start looking into as soon as they have the data available. So thanks a lot for sharing these initial results with us.
Thank you.
Okay. So this means we can move to our next presentation. This will be a presentation by Nataša Rosić from the Institute of Public Health of the city of Belgrade in Serbia. And she will be presenting insights on ill-defined deaths by age and sex in the Belgrade population between 2016 and 2020. Her presentation is available as a pre-recorded session, so I will start sharing this. If, again, you wouldn't hear the sound, just shout and I will restart.
No sound.
Yeah, it's not yet my PowerPoint is.
Mortality data provide the most important health indicators for the assessment and comparison of the health status at local, state, and international levels. Mortality statistics is one of the basic sources of health-related information, and in many countries, it is the most reliable source of health-related data. The quality of mortality statistics is closely monitored in National Statistical Office and public health institutes. Apart from the system for logical control, an indicator commonly used to signal the quality encoding main causes of death is the share of ill-defined deaths in total mortality. In this study, we focus on the ill-defined deaths. That's coded with the main cause from the 18 group of International Classification of Disease 10 revision: symptoms, signs, abnormal clinical and laboratory findings, ill-defined causes, and number of deaths in Belgrade population over the last 5 years. Annual data of ill-defined deaths in Belgrade populations are studied by 5 years age groups and by sex, and the change of the share of ill-defined deaths in total mortality was tracked over the period 2016 to 2020. Data source is the Statistical Office of the Republic of Serbia on the mortality of the citizen of Belgrade. This is result. The share of ill-defined deaths in total mortality in Belgrade was by 1/3 higher in 2020, 3.4%, than in period 2016 to 2019. Figure 1, you can see rank of dead person with a diagnosis from 18 group ICD 10 revision in Belgrade between 2016 and 2020. The 26th versus 2020 increased has equal gender distribution, 1.5% versus 2.5% in females and 2.8% versus 4.2% in males, respectively. In figure 2, you can see that due to 18 ICD-10 revision, by sex in Belgrade in 2016 and 2020. The majority of ill-defined deaths in female and male has moved to older age groups from 18 to 18.4 to 18.5 years and more, and from 16 to 16.4 to 16.5 to 69 years, most probably due to aging of population. Upgrading the knowledge of physicians responsible for death certification is necessary to decrease the share of ill-defined deaths in the overall mortality. This research has provided a broader view of the quality of coding data on the underlying cause of death in death certificate in Belgrade between 2016 and 2020. In Belgrade, almost every 30 death in 2020 was ill-defined. More male than female deaths are ill-defined in 2020 in Belgrade. Thank you very much.
Okay, perfect. Thanks. Alexander, I see that you're still sharing your screen. Maybe you can.
Sorry, Brecht, I don't know where to stop, how to stop it.
On the top of your screen, you should see an orange menu, and there the left button should be stop sharing. Do you see that?
Unfortunately, no. Just let me see.
Okay, I think I managed to.
You managed. Thank you for that.
Yeah, thanks. No worries. Let's have a look. I'm not sure if Natasha is in the call to answer any questions, or maybe any of the colleagues who were involved in this work are in the call.
I can try and answer some of the questions if there are some. Just like
yeah. Sure. So let's have a look at our chat. I don't see any.
This was me replying to Grant, who skipped his question, but yes.
Yeah. And one thing that I was wondering, because you are referring or comparing to 2020, which is of course also the COVID year. So do you think that COVID, directly or indirectly, could have had an impact on the higher frequency of our chapter codes?
This is an interesting question. Thank you, Brecht. Also, our statistical office compares everything it does to the previous year. And this was okay for 2020 because you were comparing it to 2019 when there was no COVID. But now with new results, I don't think it's a good point of reference. And, you know, there is a discussion between the scientists, should we take a 5-year period or a 20-year period? Or so this is something we should also harmonize so we can actually compare data. It's very also important for the excess mortality because, of course, in terms of population, some populations are shrinking. And then, okay, in 5 years periods, maybe you cannot capture everything what is happening, some seasonal changes. In some countries, even, you know, migrations, like it's a case in Eastern Europe, or war, and etc. So this is something we should also be careful about when we interpret the results. Who is responsible for the death certificate? So Statistical Office of Serbia is the responsible for death certificates. It collects all the death certificates and then makes it vital statistics. But we have other data holders, of course. But this is the most reliable one.
Okay.
May I add something?
Yeah, sure. Go ahead. Go ahead.
The problem of expected number of dates has to be computing taking into account the secular trends in various age groups. In fact, if you use the previous 5 years, you underestimate the expected number of deaths. Because mortality, you overestimate because mortality has been decreasing with a secular trend. So you have to extrapolate starting from the last available point, which is usually 2019, and you should not use the 5 year 15 to 19, but try an extrapolation to 2020, which is very easy. In fact, it's commonly made. Thank you.
Thank you, Carlo. For example, another interesting thing is that at least in this part of Europe, we had this baby boom generation and this generations is currently entering their 65s and 70s, so which is also the most sensitive population in the pandemic, where age group where we see the most death counts. So also, who knows, we should take into consideration that maybe we would have normally, even without COVID, a fine increase in the mortality due to baby boomers being older and reaching the life expectancy. So there are many variables which should be taken into consideration, but you're definitely right. I think also 5 year period is very short.
But if you use age-specific rates, the problem of the different size of different age groups is solved.
I'm talking about absolute numbers now.
Yes, of course. Okay. And then you arrive at absolute numbers. I can send you a paper of ours where we take into account of this. Okay, if you send me your email, I will send it to you.
I would appreciate that. Thanks. You very much.
Yeah, and feel free to put it in the chat, Carlo, so that everyone can see the link. Thank you. Thanks a lot. There was also a question from...
I'm just not able to put it in the chat, but I will try to send it to you. If I have your email, I'll send it to you.
Yeah, perfect. Thank you. There was also an interesting question from Lorenzo. So here you focused on ill-defined deaths, defined as the R chapter of the ICD-10 classification, but of course ill-defined deaths can also be causes that are not to be considered as underlying cause, such as sepsis, or ICD codes that are unspecific, such as cancer unspecified. Did you also have a look at those codes to have a broader definition of ill-defined deaths?
Here, I'm just trying to see where is the question, so I can read.
It was just before the question of Konstantin.
Also be ICD causes.
Yeah.
The underlying causes, yes. Other than ICD causes that are not specific cancer. So how did you manage it? Yes, of course, this is a big problem, and there are many. We were thinking to use the Anaconda. So if you're thinking about redistribution, this is something yet to be defined. But I definitely agree. Some kind of internal control is also done by the statistical office. So they are the first filter to that, but of course they do not have time, neither the resources to deal with the redistribution of garbage codes. So this is for us to do, and we'll discuss. We'll try different methods. So far, I don't have any experience right now with the redistribution, but I'm looking forward to dive into that. So yeah, thank you for pointing that out. And I see there is another from Mark, if we have time.
If you can answer that very quickly, yes.
Serbia has data on the risk factors such as substance use disorder and physical inactivity. Not that I'm aware of. We have some observational cross-sectional studies, but not something systematic like this, no.
Okay, thanks. Thank you.
Thanks, everyone.
All right, so thanks for the nice discussion. So this means that we can move on with our program, and our next speaker will be Sara Conti from the University of Milano in Italy, and she will be talking about temporal variations in the burden of ambient air pollution in Italy. So Sarah, feel free to share your presentation and
Okay, can you see it now?
yes, yeah. Thank
Okay,
you.
so just a minute because I would like to put in the chat, just 1 second, I would like to put in the chat the link for the WooClap meeting that we're going to use in order for everyone to be able to connect to the WooClap. Okay, can you see my presentation now?
Yes, thanks. We're seeing the
Okay.
presentation again. Thank you.
Thank you. First of all, thank you very much for giving me the opportunity of presenting this work. And I'm presenting on behalf of a larger group because I'm presenting on behalf of the Environmental Exposures and Shocks Working Group within the Italian Global Burden of Disease Initiative. So since I've seen that the interest in air pollution burden is very high, yesterday I saw that there's a task force that's going to work on this. I would like for you to give me some feedbacks about what I'm going to present. So please, if you wish to connect to this WooClap link, I will ask you a few feedbacks throughout the presentation. So our work is a little bit different from the others that have been presented up to now, because we work within the Global Burden of Disease study. We work together in collaboration with the Institute of Health Metric and Evaluation. And besides on collaborating in revising the estimates that are produced by the Global Burden of Disease study, we're also given the opportunity to make the most out of these estimates, because we are given the opportunity to work with the outputs of the IHME studies and to lead collaborator papers that can focus on different aspects of the burden inside for example, inside our countries and so on. So the aim of this work was to make a little bit of translation of the knowledge, because we wanted to focus on the burden of the disease for long-term exposure to ambient PM 2.5 and ozone in Italy. And we also wanted to separate the contribution of changes in pollutant concentrations from those of population dynamics, because this is essential to understand if the policies that are taken as a measure to lower the exposure to air pollutants are actually effective. So the risk factors that are considered within the global burden of disease are particulate matter and ozone. These are the only two risk factors that are connected with ambient air pollution exposure. I'm not talking about indoor pollution. So the exposure assessment is carried out on worldwide grid estimates, and then a national level population weighted mean concentration is used to compute the population attributable fractions. The risk estimation is carried out on those risk outcome pairs that are validated for inclusion using scientific literatures. And these risk outcome pairs should reach the status of convincing or probable evidence in the World Cancer Research Fund grades. So, first of all, I would like to ask you if you think that these two outdoor pollutants can properly synthesize the outdoor pollution effects. I will give you just a few seconds to answer to that. So I see the opinion is not the same for everyone. It's not homogeneous. You are divided. So I see that we're going towards the no. Just a few seconds more. Okay, I think we can progress to the next. Someone is still voting. We can maybe progress to the next question then, as I see that most of you answered no, and this is what I was expecting. Then I would ask you to type a few words to tell me what other pollutants should be included in the assessment. I see there are no answers. But I asked Bart if the instrument is active.
Yeah, it's working well. People need to click the submit button after they have typed in their suggestion.
Okay, maybe we can progress and think about this maybe later or maybe in the next session when we will discuss maybe air pollutants burden. So
I think, sorry, there was an issue with the
there was
WooClap.
an issue.
I wasn't able to send in my answer, sorry.
I'm sorry. I'm sorry, maybe we can discuss it with another instrument. I don't know what is not working.
People can also put their answer in the chat and then you can have a look at that.
Okay. So as far as now, nitrogen dioxide, this is going to be considered in the next global burden of disease round of estimates. Sulfur. PAN. Okay. Thank you for your feedbacks. We can now proceed to the next slide. These are the risk outcome pairs that have been identified as validated by the Global Burden of Disease 2019 round. So for particulate matter, we have cardiovascular and stroke outcomes, so ischemic heart disease and stroke, chronic obstructive pulmonary disease, lung cancer, acute lower respiratory infections, adverse birth outcomes. You won't see anything about those in Italy because the impact on those is very, very low, and type 2 diabetes. As for ambient ozone pollution, we only have COPD and years of life lost for COPD, to be more precise. Do you think that there are other risk outcome pairs that are missing and that can potentially impact the final estimates? So for risk outcome pairs you would consider very important to be included in this assessment, besides those that we already have? So if this is not working, please type them in the chat. No, dementia.
I've typed in some answers, but can you click on the left-hand side? Maybe you are hiding the results. Maybe that's why. So on the blue button, for instance.
Sorry, just a minute. I exited. Okay.
So on the left-hand side, the blue button.
The blue button on the left.
All the way to the left. Yeah. Can you click on one? Sometimes if you click it, hides or unhides the results. Can you click again on the sort by?
Yeah.
No, nothing.
Nothing.
Okay.
I'm sorry for this malfunction.
Yeah, no worries.
So I think we have one answer in the chat, right? So asthma. Okay, thank you, Brecht. And this will be associated with an O2 in the next round. So I can confirm that this will be taken into consideration. Dementia is not considered as yet. So maybe we can progress to the next one. Our analysis focused on results from the Global Burden of Disease Results tool. We downloaded crude and age standardized rates as for dailies, deaths, YLLs and YLDs attributable to ambient particulate matter and ozone from 1919 to 2019. We also downloaded the percent variation of this burden, the percent rate variation in the attributable burden. And we also downloaded the percent rate variation in the overall burden of all outcomes associated with the two pollutants of interest. So not just the share that is due to particulate matter, but the overall burden of these diseases. So our analysis consisted in two parts. The first one assessed the role of population aging in what we observed. So we compared the temporal variations of crude with age standardized rates, because the difference gives you a picture of how the aging of the population is impacting the attributable burden. Then we evaluated the role of disease dynamic, because we compared the temporal variation in the overall burden, so for the overall outcome of interest, the overall disease of interest, and the trend that we observed for the attributable fraction. I will now proceed to the results very quickly. Here you can see the results for particulate matter in terms of disability-adjusted life years rate per 100,000 person, then mortality rate. Then we will also see YLDs and YLLs. What you can see here is that the crude rates, so the blue points, the blue dots with confidence intervals, are higher than the age standardized rates. And that gap that we can see is the effect, the impact of the aging of the population. The same can be seen for years of life lost, while there is no clear trends in years lived with disability. As for ozone, the trend does not exist. So we don't see any clear decreasing trend in the burden of ozone. Now, if we focus on the percent variation, we compare the percent variation of crude rates and age standardized rates, you can see the blue bars represent the crude rates, the decline in crude rates, and the age standardized rates. What we can see is that the percent variation in the age standardized rates is always more pronounced, or almost always more pronounced than the variation in the crude rates. That means that somehow aging of the population is counteracting the beneficial effect of the decrease in the concentration of the pollutants, because the elderly population is more susceptible to the effect of particulate matter and ozone. This is what happens with ozone, and as you can see, there are two different trends. In 1990 to 2010, there is a decrease in the burden, while from 2010 to 2019, there is an increase in the burden. If we now focus on the comparison between the trends in the overall burden of this condition and in the burden due to air pollution, what you can see, especially if we focus on 2010 to 2019 period, is that the decrease in the overall burden of these diseases is always much lower than the decrease in the attributable burden to particulate matter. Obviously, ozone is an exception because the burden increases. So this means that the decrease that we observe in the attributable burden is actually due to the decrease in the concentration and not to population dynamics or to the disease dynamics. So now, do you have any criticisms about these comparison methods? Was I clear? Was I not clear? I see one person is logged in. Just a few seconds to give you the opportunity to raise criticisms both in chat and in book club.
So I think it's again the same problem. So I typed in an answer, but it's not appearing on your screen here.
I'm sorry. I'm very sorry.
Yeah, best to
We can
suggest
go on,
in the
and maybe if you have any criticism, you can ask, you can say it during the discussion. So let's progress to the conclusions very quickly. Our study showed an overall decrease in the burden of ambient PM 2.5 and gave strong evidences that the regulations aimed at reducing the exposure had a beneficial effect on public health, because we saw the burden reducing, and that burden declined more than that of the overall condition. However, it also highlighted that the regulations that are currently still effective for PM 2.5 are not effective for zone. So, and finally, that the population aging leads to an increase in susceptible population that is partially counterbalancing the beneficial effects. So I think that we wanted to give an example of how we can use these estimates to give some information, some crucial information to policymakers about what they're doing with environmental regulations. The impact of this environmental regulation is usually very hard to understand and to estimate. So thank you for your attention. And this is the whole working group that has been working for 1 year now on this paper. And I thank every one of them. Here you can find my contact if you want to ask something or any information. Thank you very much for your attention.
Yes, thank you very much, Sarah, and thanks also Lorenzo and everyone else from the Italian GBD initiative who's attending the meeting here. Thanks a lot for the great presentation and the great initiative and collaboration that you have set up in Italy. I suggest we open the floor for one question and then we move on to our final speaker in the oral presentations section. Looking at the chat, so Peter did refer to dementia in as one of the outcomes. So is this today already included or not yet? And if it's not yet included, what would be the process for including this in future iterations?
So the inclusion in the iteration depends on the validation process. So you need to reach to have enough evidence, scientific evidence, to fulfill those criteria I talked about in the presentation. So I'm not aware of the inclusion of dementia as yet, but I need to, you know, this is a constant process of updating and including new evidences. I'm sure about the inclusion of the connection between asthma and NO2. As for dementia, I'm not sure it was recently included.
Mm-hmm. Okay, thanks a lot. Thanks. So then I suggest we continue with our final presentation. So thanks once again, Sarah and colleagues. And our final presentation will be by Matthias Luchmann. Just a second. Who's working at the Hessian Agency for Nature Conservation, Environment and Geology in Germany. And he will be presenting estimates of environmental burden of disease linked to road traffic noise in Hesse, Germany. So Matthias, thanks a lot, and feel free to share your screen and start your presentation.
Okay, can you see my presentation?
Yes, very well, thank you.
I'm also trying to get some feedback from you, and I tried with Menti. I posted the link, but we'll need that only in the end of my presentation. Okay, well, somehow my topic is related to the one of Sarah. I will now speak about noise, which is everywhere, more or less, like PM10 as well. The difference in my case is I don't have big collaboration. I'm the only one in my agency working on the burden of disease topic at all. And I don't have medicinal or very little epidemiology background, only physics rather. So, but we funded a study in from the working group of Andreas Seidler in Dresden. And we published together a paper, and a bigger report is going to come. I'm trying to click my presentation. It doesn't work. Wait a second. Ah, okay, now. In agencies, we do not do things because they are so very interesting, but rather because we should. And we have a law called European Noise Directive, and it has different aims. The first one is it asks us to determine the exposure to noise, and this was our duty, and we did it. So this is an example map of a small city in Hessen, as we should have done it, and we did it like this, but we also did a better mapping, lower thresholds and more complete transport net and so on. Well, we have done this. But the second objective is to ensure information about noise and its effect. And this was kind of the reason why we financed this study. Well, there's still things to do, but we partly managed to get some information about this. And of course, it should be leading to something, to making something better, reducing noise where the exposure levels are too high. Somehow they put this sentence here, where exposure levels can induce harmful effects. And of course, I guess you know, really it depends on where you set the threshold. And this, well, that's a kind of crucial question with no good answer so far, as I see. But I think it's worth having a look on the definition of health. We use the WHO definition of health. So health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So of course, this means that if you feel highly annoyed or highly sleep disturbed, you're not at complete health. And we follow the Umweltbundesamt, the federal agency, in the opinion that one should include the endpoints like high annoyance with a certain disability weight. Not everybody in my business in noise has the same opinion, but our agency follows this opinion. And actually here I cited Tobolik and also Plus. This paper, we oriented us at this paper, but we did something different, and some of the things I will show here. So how does it work to calculate the burden of disease from noise? We started with our detailed noise mapping. We call it class mapping because it's more than we needed to do. We needed population density map on house level, and it results in an exposure distribution, actually in many different exposure distributions. Unfortunately, we need to use 3 different noise metrics, 24 hours, and day, evening, night, or only night levels, sound pressure levels. And also you need to look carefully on whether it's on the loudest facade or on every facade. It's a difficult topic, but well, we just needed to do it, and we needed to do some assumption as well. But it's the best what we can do. It was the best we can do. Now, of course, we need some dose response curves. For example, for depression, and this here is for annoyance, for example. And we integrated this in a model. And if you watch these graphs, it's both times the same x-axis. Well, these x-axes are similar, but these are exactly the same. So the exposure here corresponds to the dose response function here. And of course, you can see that this red line is the resulting out of the mapping we have done according to European Noise Directive. And there's missing a lot, especially towards the lower end. And then it becomes really crucial whether you set the threshold here or wherever. And this topic is, to my knowledge, not addressed properly so far. And I would like to draw your attention also on this curve once again. This is from Guski. So, well, in the noise business, this is a very famous paper. And they made a big data meta-analysis on many individual papers, and they fitted different lines on it, different dose response curves for level, resulting in high annoyance. In my opinion, one should have taken more care about how to fit it and how deal with the data, because depending on how you fit, you do not see any threshold behavior. You never go down to zero. And of course, this is well, this might be a problem if you watch the whole exposure data. But we moved on. We didn't have anything better, so we moved on. And this is kind of our result. Well, in a lot of detail, but I will go through quickly. These are 3 different data sets for exposure we used. So European Noise Directive data, or better mapping, or hypothetical scenario with a reduction of 3 decibel. And this here is depending on which endpoint you watch and the result of burden of disease. We need, well, because we see different variants of, for example, heart burden of disease, and we chose certain sensitivity analysis. I will not go to detail, but the more interesting thing is the comparison to other risk factors from the Global Burden of Disease study, which I try to do here. The black and the blue data points are the risk factor burden. Now, the burdens due to the different risk factors in the Global Burden of Disease study from 2019. Here, the blue point, or the blue means environmental risk factors. This is about the PM2.5, which we have heard before. And here in red, I put a few of the data points of our sensitivity analysis, the result of our study, which is kind of comparable to PM10. And for example, it might be higher than diet high in processed meat, for example. And of course, with this new information, new knowledge, we would like to do some policy informing. And as we have low or no experience with the burden of disease so far, I'm glad I can present here in this network. And I would like to ask you whether you can write some comments on these 2 questions. So one more general about what is missing to establish the traffic noise as a burden of disease risk factor, and the other one, what are arguments for or again burden estimation for local environmental scenarios? For example, if you watch on the neighborhood of an airport or a road or something, if your population is not whole Germany or whatever, but rather restricted, are there arguments for or against such? So I have posted the link, and I will see whether now the feedback works. I will try to show it. Okay, at least one.
So it's indeed working, and you had put the link in the chat, so
yeah, that's it.
Everyone feel free, and you can add multiple answers, I believe.
Yeah, that's it. That's true. Yeah, of course, these are good questions, whether there's enough scientific evidence. And my view is only, I haven't seen all of it, nothing. There's nothing missing here. In my opinion, there's some evidence, and our study also shows this, that there's more. I don't really understand what's the point. Okay. Okay, thanks. You can continue to write there, and I'll also start the next question. Try at least. Yes. What are arguments for or against burden of estimation for local environmental scenarios? If the population is not very big, but restricted to maybe 10,000 persons or so. Because this would be our use case for our agency.
And I see people have to click next question to go to the second question.
Thank you. Okay, I will leave you writing more. And what I forgot to mention, our results we obtained. I calculate a lot with R code, and I published this on GitHub. So if you're interested, well, I would be glad if somebody could watch the code or help, or I can we can share code and also data which I have online. So if you're interested, just write an email.
Yeah. And Matthias, I think this is an excellent piece of work that you've done, and feel free to use our network, maybe especially the German colleagues that are part of the network, or the people with expertise in air pollution and noise. So please try to make use of our network to support your activities and your needs, because that's why we are here to help support people like you who are maybe new to the world of burden of disease. So we are there to share our experiences and expertise with you. So thank you.
Yeah, thank you.
Okay. Great. I don't know if there are any specific questions for Matthias at this stage.
I see two in the chat. How about household insulation against noise? Yes, of course. We can only map the noise which on outside of the houses. So far, okay, there are estimates how you can how to calculate the noise inside the house. So far we cannot. But well, of course it's problematic, but it's not so very problematic, because both the dose response curves as our exposure data have the same problem. So it kind of cancels out. It's not perfect, but it's somehow possible. And apart from, is that fine? No. Apart from high annoyance, which other health outcomes were included in your burden of disease estimates for environmental noise? Okay, I went over it quite quick, a lot of detail. So there are cardiovascular disease, depression. Okay, you have to put a big question mark on depression. I'm not so convinced that you should really put it in like this, but it's in there. For heart, there's also ischemic heart disease, according to WHO scheme, and sleep disturbance. This is the other big contribution, which is only due to the WHO definition of health, which classically could be skipped out, as well as annoyance.
Okay, thanks. Dietrich, you have a comment or question to follow up on this?
Yes, I just wanted to make clear, noise is a very important risk factor, and I think it should be more and more included in environmental burden of disease assessments. However, if we see this nice graph here, there is a lot of uncertainty around the estimates. And the thing is that even though there is uncertainty seen here, there's also uncertainty regarding the evidence. And when you look at the guidelines from the WHO, you will see that the evidence is like really diverse between the different health outcomes. This is something that needs to be considered very carefully, because these all outputs here have different levels of evidence. This needs to be made very clear, because even though probably the disease burden for a certain outcome is very high, it could be that the evidence behind this outcome could be very low. So we need to be careful, and this needs to be presented together with the results, of course.
Okay, you're right. Thank you for this hint. Of course, I'm aware that there's not perfect evidence for all of these endpoints, and there are big question marks in some of them. Another question also asked about uncertainty for sleep disturbance. Well, we could not assess this. I could not. I think it's possible, but in at the level we are, we could not do it. And of course, this is something to be done before you can include it in the GBD, for example, of course.
Okay, thanks a lot. And so thanks once again, Matthias. And please know that, yeah, we as a network, we are there to help you and support you. Dietrich, final word on this. Thank you. Or it's still the old hand.
Okay, thank you.
Perfect. Thanks a lot. Right, so this means that we are at the end of the oral presentation sessions. We'll have another short break until 3:35 Central European time, so 4-minute break. And then we will have the pitch presentations of the posters. The posters are also available as PDF via our website. So if you want to have a look at them in detail, please make sure to go to the website and yeah, open the posters there. But we'll be back in a couple of minutes. Thank you.
Sorry, Brecht, are you there? Can I ask you a question?
Yeah, I'm here.
Yeah, sorry, my presentation had a typo and an extra slide, a copy of another slide. May I send you the updated version to be uploaded on the website, please?
Yeah, sure, no problem.
Okay, thank you.
Thanks a lot.
I'm sorry. Thank
No,
you.
no worries. Thank you.
Brecht, I have one question. Do you share the poster or do I share?
Unless you really prefer to share as yourself, I would like to share from my end, because then it's
Yes, perfect. Mm-hmm.
easier to go from one to the other.
Yes, thank you.
Okay, so let's get started. So our first poster will be presented by Aline Anton and will present the Katinka project. So Aline, feel free to go ahead.
Thanks, Brecht. I'm very happy to introduce you to our Katinka project from the Robert Koch Institute. The aim of the Katinka project is to build a bridge between the Burden EU cost network and countries located in South Caucasus and Central Asia. And the project supports the implementation of burden of disease methodology or other summary measures as an important tool for health information and policy development. And based on the knowledge that we gained from the National Burden of Disease Study in Germany, Burden 2020, we do that mainly by training opportunities and workshops, and some of them we will also do together with COST, and short-term scientific missions supporting also PhD thesis and master thesis. If we have a look at the timeline, it's a 3-year project that started in 2021. And what we did first was that we had the opportunity to meet all our partners, most of them in person, and that they gave us an overview about their data situation, and together we did some kind of needs assessment together and how we can start with calculating burden of disease or summary measures. And yeah, the goal is to enhance the use of these data and to calculate, for example, burden of disease indicators based on the data situation. And since some of the partners are more into training and capacity building first, and who they want to introduce the projects to, for example, their Ministry of Health, some will start their own pilot studies based on a selection of diseases, for example, cancer or diabetes. Some of them have cancer registries and they aim to calculate the burden of cancer. And that's what we want to do next. We will start the next online workshop soon in February. Yeah, and yeah, we'll share how we did it in the burden of disease study in Germany and how other people maybe did it. We heard some examples today for burden of cancer. And the long-term effects hopefully are a strong network, capacity building, the integration into health reporting, and also the knowledge transfer to policy. Thank you.
Yes, perfect. Thanks a lot, Aline. And again, a nice example of a collaborative project supporting capacity building. So thanks a lot for that. Let's have a look at our next poster. This will be presented by Ali Kilinc and will focus on tuberculosis disease burden. So Ali, feel free to go ahead. Thank you.
Thanks, Brett. Hello, everyone. My name is Ali Kilinc. I'm from Turkey. I work as a public research assistant at Eskişehir Osman Gazi University. We conducted a study on TB burden in Turkey. It was a trend analysis, basically. TB is still an important disease. Before the COVID pandemic hit, it was the #1 cause of death among the single infectious agents. Even though it has it can be treated successfully with a 6-month medication regimen, yet it is still an important health issue for developing countries such as Turkey. In our study, we evaluated the transport TB burden between the 1990 and 2019. We used the GBD data for the TB. We excluded the TB with HIV for a study. We calculated deaths per 100,000 populations. We used the joint point regression program. It was mainly used for cancer surveillance. Our results, we found that both for females and males, the deaths per 100,000 decreased, but the decrease were more prominent in females for males. For males, we can see that the average annual person change was -6.8 for females and -8 for the males. In conclusion, the tuberculosis burden has decreased throughout the years. The decrease was much more prominent in females. Even when in our country we have a national tuberculosis program, but even with the program implemented, there's still problems with tuberculosis burden in our country. Thank you for giving me this chance to present.
Yeah, thanks a lot. If there are any questions, I suggest that you can answer them in the chat. So Ali, I've seen a question from
Yeah, I see.
I believe it was, so please feel free to answer them in the chat. Thank you.
Yeah, there's possibly due to the rest of the patients, the rest of the tuberculosis patients are the ones that are very hard to reach after some time. They have a harder time to access to health services. TB is known to be the disease of the poor, sadly, and these people have a hard time accessing health services. This might be a problem. Also, increase in drug resistance. Drug-resistant tuberculosis, it could be another point. Thanks for the question.
Yeah, perfect. Thank you. Thanks. Right. So then the third poster will be presented by Carla Martins. Carla, feel free to go ahead. Thank you.
Hello, everyone. Good afternoon. So I'm presenting this work about the PM Cards Impact Project, and this project is going to be focused on the fact that air pollution is the largest environmental cause of disease and premature death. And we will specifically deal with the causal relationship between the exposure to particulate matter 2.5 and cardiovascular morbidity and mortality. So our aims will be to assess the exposure of the Portuguese population to PM 2.5 and to estimate the burden of disease and the economic impact of these pollutants related to cardiovascular disease in Portugal, and also in the end integrate all the data and identify the areas for cost-effective public health interventions. So we will use the national and European air monitoring platforms to assess the exposure, and then for the burden of disease, we will first outline our disease model and estimate the disease burden attributable to exposure to PM 2.5 and express this burden in DALYs. And for the economic evaluation, and since there are many gaps, many data gaps in Portugal for these matters, we will use a group of experts and do an elicitation to fill these gaps regarding the individual direct and indirect costs for these diseases in Portugal. So in the end, everything will be integrated, and we hope to provide the policymakers with supporting information to act for the reduction of air pollution maximum levels. Thank you.
Okay, thanks a lot, Carla, and very happy to see that there's a lot of new initiatives on air pollution and related stressors. So I think there will be a lot that we can learn from each other and share and exchange. So thanks a lot for presenting this. Then next on the schedule is Jovana Todorovic from Serbia presenting insights on the burden of breast cervical and colorectal cancers in the countries of the former Yugoslavia. So Jovana, feel free to go ahead. Thank you.
Thank you. Hello, everyone. So yeah, I will present basically the trends in the burden of breast, cervical, and colorectal cancers in 6 countries of former Yugoslavia. That is Slovenia, Croatia, Bosnia and Herzegovina, Serbia, Montenegro, and North Macedonia. As these cancers are well known to be treatable if diagnosed in early stages in the disease. So we basically analyze the trends of disability adjusted life years using the GBD database. And the data we used for this analysis were data from 2019 GBD study. I think it is a bit small figure, but I think that everyone can see that the highest burden of breast cancer throughout the period was in Serbia. as was the burden of cervical cancer. And I think on this picture, NO2, you can see how Serbia is way higher than other countries, while the highest burden of colon and rectum cancers was in Croatia throughout the period pretty much, except around the year of 2000, where just for a short period of time, the highest burden was in Slovenia. But that is actually the year where Slovenia started introducing obligatory screening. So that is when they had a slightly higher burden and disability adjusted life years, but then you can see that Slovenia significantly decreased the burden. And that's basically the main conclusion. So the burden of colon and rectum cancers is expecting to increase in 5 out of 6 countries of the former Yugoslavia in the next 10-year period, except in Slovenia. The burden of breast and cervical cancers is significant, and the highest burden of both breast and cervical cancers out of these 6 countries is in Serbia. That would be that. Thank you.
Okay, thanks a lot, Jovana. Thank you very much. Then our next presentation is a pre-recorded presentation. So I will maybe do it this way. If you don't hear anything, just shout, and then it, of course, needs to start. So just a second while my PowerPoint is loading.
Welcome to this poster presentation, a case study understanding the economic impact of COVID-19 on health systems by myself, Neil Chalmers, João Vasco Santos, Diana Alexandra Grad, and Grant Wiper. The aim of this work is to estimate the economic impact of COVID-19 on health systems in various countries in terms of health expenditure. Let's provide some background. It would be very useful to understand the expenditure allocated to health systems, and health systems still to be defined, but going beyond the actual provider of health. So maybe also looking at long-term residential care for future pandemics and understanding the resilience of these systems. This also allows us to identify how health budgets are constructed across our initial 3 countries of interest, being Scotland, Portugal, and Romania. We'll be conducting literature or rapid reviews on the immediate publications and studies looking at the expenditure on COVID-19. And this should be very helpful for our research, but then we'll actually be looking at the data from the accounts of these different countries. It's obviously very early days, as this is a case study and a methodological-based case study. But for example, we know in Scotland that it's been estimated that 1.67 billion are the costs associated with COVID-19 for the years 2020 to 2021. Except this excludes, for example, long-term residential care. This is only focused on expenditure towards the National Health Service within Scotland. So we need to actually work out what other areas represent a health system. This will be an international collaboration, providing capacity building for future pandemics, and hopefully allowing increased ability for applying future health economics to the area of burden of disease framework. It again is an area which is so far receiving little attention within studies about actually how do we define health systems and what are the expenditures.
Okay, thanks a lot. And indeed, nice to see these collaborations occurring within our network, and also nice to see that here and in other presentations, the economic aspect is also taken into account. So this is an important thing that, although we don't focus on it as a network, it is still, of course, very relevant. Right, then our next one is also pre-recorded. So again, if you wouldn't hear the sound, just start shouting and then I will restart. Right, then now I'm not hearing myself.
Dear colleagues, good afternoon. We are very glad to be with you today and that the Burden EU cost action functions very well despite all the difficulties. I will present you today the calculated disease burden of COVID-19 in autonomous province of Vojvodina in Serbia for the period from July 2020 to April 2021. The overall disease burden caused by COVID-19 in Vojvodina was expressed by disability adjusted life years. The protocol for country studies given by the European Burden of Disease Network was used for the burden estimation. The incidence of 65,535 new cases was extracted from the database of the Institute of Public Health of Vojvodina. The gender and age classified cases were divided into 3 groups with different disability weights. One, COVID patients who were cured only by the assistance of primary health care system, and the second group were hospitalized patients, and the third group patients who needed the vital support and were hospitalized in the intensive care units. This is the classification suggested by the Burden EU authors. Registered cases as well as post-COVID cases were not included in while the estimation due to insufficient data. The average duration of the disease, depending on its severity, was extracted from another study, and here is the link to the study. Life expectancy for years of life lost was taken from the regional life table. The disease burden expressed by per 100,000 was 1,259.26 DELIs, which was higher in men than in female, while the expressed per 100,000 was 4.54 for females and 4.43 for males, but the YLL was significantly higher in men than in women. Age and gender stratified DELIs is presented by this figure, and the COVID has been posing an increased challenge for the health system in Serbia over the past year. DELI metric, composed mainly of the YLL component, depicts well the condition of the affected population. And at the end, I would like to thank the Burden EU authors for helping me with the study planning. Thank you very much.
Okay, great. Thanks a lot, Tiana, and you're also here with us, so thanks a lot for this. And we can move on to our next and final poster. You should be able to see now, yes. So this will be presented by Zornica Mitkova from the Medical University of Sofia in Bulgaria. So Zornica, please feel free to go ahead.
Thank you. Hello, everybody. First of all,
Oh, we don't hear you anymore. Connection seems to be problematic. Maybe let's wait one more minute. So Nitsa, do you hear us again? Okay. That's a bit unfortunate, of course, but okay. I suggest for the interest of time, you all have the poster in front of you and also available through our website. So don't hesitate to have a look and reach out to Zornica if you would have any specific questions. Right, so this was a quite intense session, but I think it was worthwhile to see the activities of all of our different colleagues. This also means that we are coming to the end of our meeting. And to wrap up this session, I want to go over with you again over the next steps. I've also talked about this yesterday, but it's good, I think, to remind everyone. So important for all of you to register as a working group member via the links that you find on our website, because this will help us guarantee the financial sustainability of our network. Please take advantage of the open opportunities for training schools, the mobility grants, the webinars that will again be launched. And yeah, as you all know, please don't hesitate to use the network to your advantage. Yesterday, we've also introduced the concept of task forces. In addition to the COVID-19 task force, which is already quite active, we also asked you to propose new ideas, new suggestions for task forces. And some time ago, I made a summary of the ideas that have been suggested so far, and we actually have quite a number of ideas. The list is even growing. But you have raised suggestions on social inequalities in health, estimating disease severity, and many more topics, as you can see here. And this is very encouraging. So what will happen next is that we will get in touch with the people that have listed themselves as coordinator to have a chat and see how we can set up this process together to answer any possible questions that may still be out there. For the task forces where so far no one has listed themselves as coordinator, we will reach out to the different people that are listed as members and discuss with them how we can encourage one of the members to take the lead in this task force. So this is indeed very encouraging, and we will actively take forward these ideas over the coming weeks and months, of course. To really wrap up, I also wanted to take a group photo so that we can have a souvenir of this meeting. So for this, I would like to ask everyone, and you're already doing this, thanks a lot, to switch on your videos. Myself and Grant, we will be taking some screenshots. We will also use this for our website and social media, so please make sure that your hair is in the right position. Thanks, Bram. Okay, we will need to make a number of snapshots because you don't all fit on the same screen. So you will have to hold your smile for a while. Okay, let's get started. So 3, 2, 1, first one. Okay, perfect. Just a second for me to find a way to save this. Okay, sorry. Then I'm moving the screen, so let's go for a second snapshot. So once again, 3, 2, 1. Right. Yep. Okay, perfect. Great. So we cannot guarantee that you will all be listed on the photos, but yeah, this is one of the disadvantages of doing this digital. But at least we have a broad variety of pictures. So thank you all very much for willing to participate in this photo moment. So this means that we're really at the end of our meeting. I want to thank you all once again for being here with us, for having contributed in different kinds of way to the meeting. Also want to end with this inspirational quote. As we all have known, the difficulties the past few years in our personal life, professional life, of course, also with our cost action. But I'm fully convinced that difficult roads will lead to beautiful destinations, so that all the efforts that we have put in maintaining the network will will become useful to guarantee the sustainability and the nice outputs and activities of our network. So once again, thank you all for everything that you have been doing for the network. Please feel free to keep taking advantage of everything that we have to offer. And I'm very much looking forward to seeing you again, hopefully next time in real life, maybe in one of our training schools or in our next meetings. So thank you all and have a very nice rest of the day and see you later. Thank you all. Thank you.
Thank you.
Bye.